Hi. This morning we've been called to a 69-year-old female. She woke up at 8 o'clock this morning, went in to have breakfast. Her husband noticed that she had some weakness in her right arm and her speech was slurred. He's called the ambulance. On our arrival at 9 a.m, these symptoms have resolved. So as we arrive at the job, we're checking that the scene is safe. We have our gloves on. We're walking into the house, and we are looking at the general environment, checking to see if these people are managing to cope as they're living, what state the house is in, if there is any medications left lying around, any medications close to the patient. We are then coming and introducing ourselves to the husband and wife. Hi, my name is Bruce. What's your name?
Emma.
Hi, Emma. Yeah, your husband's called the ambulance this morning. He's a little bit worried about you. Is it okay if we do an assessment just to see what's going on, making sure that you're feeling okay?
Yes.
All right. Thank you very much. So the initial part of our assessment again is assessing the airway, breathing, and circulation. So by engaging in the conversation with Emma, we can ascertain that there is no issue in those three areas primarily. The next area that we want to look at, we use a mnemonic called AVPU, that's AVPU, and that is checking to see whether the patient is alert, which she is. If she wasn't, we would then check if she's alert to voice, so we would call Emma and see if she responded to us. If she was not responsive to that, we would check for pain, so we would inflict some sort of pain, like squeezing of a finger, to see if she would then be alert to pain. Or the U is if the patient is totally unresponsive. Part of this assessment as well, if they are responsive or to what level they are responsive, is assessing their Glasgow Coma score. That's the international assessment score for a patient's level of consciousness. So we've talked about checking all around, checking the patient's mental status. If we might suspect that there may be alcohol involved or there may be drugs of some sort involved. Specifically from the initial call, we may be suspecting that this patient has had a stroke. So we would be initialising our rapid assessment or FAST test. Our FAST test allows us to look at the patient's face. We're looking for facial droop of one side. We can ask the patient to show us their teeth. If their mouth opens lopsided or poke their tongue out, their tongue might stick to one side. That would indicate that there is an issue there along the FAST score. We would also then ask the patient to raise their arms in this nature, to turn their palms upwards and close their eyes. And we're then looking for drift of some sort, which would also indicate that there is some cranial issues. In talking to the patient, we're assessing their speech, whether their speech is slurred, they have some dysphagia, they're muddling up words. And the other part of our FAST test is the time. So how long ago do we suspect that the stroke may have occurred, as these patients are specifically time critical for definitive treatment. Moving on from there, we would ascertain a full set of baselines with the various types of stroke being ischemic or hemorrhagic. They can both be started or they can both take effect from a very high blood pressure, so we need to know that blood pressure. We also need to get a blood glucose level. We also utilise our OPQRST and our sample mnemonics for these patients, specifically looking at the patient's memory, how they are able to recall events, and their specific history, whether they've had strokes before, or if there's any other medical history that we need to know about. And part of that process is trying to look at some differentials that may have caused this issue for this patient this morning. An important mnemonic when dealing with levels of consciousness is a mnemonic which we utilise called AEIOU TIPS. This allows us to check for whether there has been any alcohol consumed, whether the patient has epilepsy, whether they're a diabetic and they may have overdosed or underdosed on their insulin, whether they have taken an overdose of medications or they've underdosed themselves on their medications, so they haven't taken the medications that are required. The other part of the assessment is the tips, if there's been any trauma, if the patient has an infection, possibly from a UTI, if they have some form of psychosis, or as we suspect in this case, if they've had a stroke. Other differentials, we've talked about diabetes. We can have general dizziness, headache, backache. There could be an issue of dementia, Parkinson's disease, multiple sclerosis, epilepsy or seizures that we've spoken about. And seizures can be caused by any number of issues, from tumour to a drug overdose. They may have had a head injury, so they may have a traumatic brain injury. They may have had an ischemic stroke or hemorrhagic stroke, as we've mentioned before. The medications, vertigo is another potential presentation, which is an issue with the inner or middle ear. Infection we've spoken about, and alcohol and psychological event. So once we've been through that questioning process, there are other issues that we look at to try and help us assess whether this person has had a neurological event. Starting with the head, we've talked about assessing their speech. We assess an issue called nystagmus, which is getting a pen and asking the patient to follow the pen and seeing if they're able to do so. We look at their pupils to see if they have one pupil more dilated than the other, which could indicate an increase in intracranial pressure. We've talked about the arm drift. We ask them to try and touch their finger to their nose. If they're able to coordinate that, or if they are missing, that indicates some event that has possibly happened. And finally, and if the patient is able to, we see if the patient can stand. If they are able to stand, we look at whether they are able to walk. Primarily, we first look at a Romberg's test, where we ask the patient to stand with their feet together, hands by their sides, and close their eyes. If they have a neurological issue, this is very difficult, and they will tend to stagger or wander off. We ask them to do a heel-to-toe test, so that coordination of moving heel to toe as they walk can exacerbate the balance issue. And just generally, whether they are able to walk and follow a direction, or whether they are tending to lean or walk over to one side, or they have a deficit in one leg. Prior to doing this, of course, we do a test where we ask them to move their legs so we can check that they do have muscle tone, and we ask them to push down on our hands on both sides, and then to pull up on our hands as well, testing that they do have their muscular tone. Once you've been through all this tests with Emma, we can decide that it's potentially that Emma has had a stroke or a TIA this morning. Although the symptoms have now resolved, we would still stress that Emma should be transported to hospital as a medium acuity patient, status 3 at this time. If she has another TIA en route, then we would adjust our status call, make her status 2, as her acuity level has become more significant, has risen. So this time, Emma, although she is fast negative for us, she has had some symptoms which would have, leading up to this, which would have made her fast positive. So therefore, she does need further assessment at hospital, transported status 3. Thank you.